interpersonal violence and an idea that is just starting to be researched called universal education. So, relationships affect our health across the entire life course, and especially in childhood. Our biology is really built through relationships. Our genetics, our telomeres, our epigenetics, our inflammatory and neuroendocrine systems are actually built relationally through our caregiver relationships. And if we're ever throughout our lifespan in a relationship in which it's characterized by power and control, and we're being hurt emotionally, physically, financially, sexually, in some other way, that can really affect our health in really adverse ways. So interpersonal violence results in a higher prevalence of illness in actually like every single organ system in the body. Chronic illnesses like asthma, heart disease, a depression, PTSD, all much more common when one is experiencing interpersonal violence. Example, the STI risk is doubled or tripled in people who are experiencing interpersonal violence. So people may actually even harm one another. This is a common thing we see using medications. One of Dean Schillinger's patients actually was admitted for a prolonged hospitalization for unexplained hypoglycemia. And ultimately, it was determined actually after the admission that the patient's husband had been injecting her with too much insulin and was using that as a tool of abuse. And sadly for me, I actually had a patient who I'm pretty sure his abusive partner withholding his inhaler contributed to his death when he was having a really severe asthma attack. So this is something we don't think of, but is really common problem in IPV. So in the community, 1 in 4 women and 1 in 9 men have experienced some type of intimate partner violence that has actually resulted in a serious adverse outcome. So there's more than this, but this is the prevalence with people who have had an adverse outcome related to it. But because violence actually makes us sick, people with interpersonal violence are overrepresented in the healthcare setting. And so a study done in our clinics here showed that 15% of the women coming to our clinics had experienced IPV in the last 12 months, and 51% had experienced this in their lifetime. So current guidelines recommend that we screen for IPV using direct questions or standardized tools. And what's been found through research is that doing this screening privately, it's acceptable to patients. It definitely increases disclosure rates. And if it's paired with an advocacy intervention, then it does actually result in the reduction of IPV. But in usual practice, screening rates are really, really low. Unless you have a really comprehensive QI program to implement this, screening rates are really low, and disclosure rates are exceptionally low in most settings. So patients have so many different reasons to not tell us about IPV, right? Fear, shame, lots of things people are afraid of, including their partner finding out. And this was, the slide where I was trying to point out to you that the disclosure-based model really results in just a tiny proportion of our patients learning about IPV and a tiny proportion of them learning about what are the resources, how would you get help with this problem. And so we really box ourselves in if we just use a purely screening approach, because once a patient either answers on a questionnaire or says to us, no, that's not happening to me, we've hit a dead end in the conversation and we're not providing them with any resources, even though they're likely to be experiencing this just by numbers, right, by prevalence. So what we're asking you to do is really, really simple. We're asking you to flip the script and actually provide education and resources to your patient before you ask direct screening questions. And so this could be really simple. This could be as simple as saying to a patient, relationships affect our health quite a bit. And if you're having stress in a relationship or someone in your life is hurting you, hitting you, putting you down a lot, threatening you, that could really affect your health. And we have lots of resources here. If this is ever happening to you or a friend, they can get help in clinic. We can give you community services and resources, or we can actually, at the General, call an advocate down to clinic to meet with you privately. And if you ever want to see the advocate, just let me know. So again, not requiring disclosure even to say that you're welcome to have a conversation with this advocate. So we can practice introducing these resources without disclosure. So one of our RFPC patient advisors said to us, this is a quote from her, "You people have so many checklists that you want us to do, and your checklists have nothing to do with why I came to my visit." So you can try to actually be in sync with your patient by presenting the IPV education in relationship to what the patient is presenting with, in relationship to their complaint. So for example, if you have a patient coming in with a headache, you might say to the patient, I see you're coming in for a headache today, and we're going to get to the bottom of this, and figure out why you're having headaches. But stress in a relationship or being hit, hurt, threatened, or put down in a relationship can actually make headaches worse. So I want to tell you about these resources that are available to you if that's ever happening to you. So where was this universal education approach researched? It actually was tested in Planned Parenthood clinics in which the medical assistants were told a universal education script in which they said to the patient as they roomed them, "We know that sometimes your partners poke holes in condoms, try to pull a condom off during sex, might throw out your birth control pills, and try and get you pregnant in some way." And then they said, if that's ever happening to you, we actually have hidden methods of birth control that we can offer you. We can offer you a IUD with a string cut short, or we can offer you a depot shot that your partner won't find out that you've had. And just that universal education script, regardless of whether the patient disclosed or not, resulted in a 71% decrease in reproductive coercion. This is a case where there's a simple solution, right, for the reproductive coercion. So it's really ripe for this type of method. So there's another potential benefit that hasn't been well studied yet of providing universal education, but I think we really have to, if we want to bend the curve on breaking the cycle of violence, we really have to think about. So people who are experiencing IPV are overwhelmingly more likely to go to family or friends for help than to come to us. And that's what we're finding in our research here at the hospital as well. 60% of our patients have no intention of ever disclosing to us or speaking with us of the women in our study. People say that their family members and friends actually often are not entirely helpful to them. They say that they're blamed or shamed, or that sometimes their family members or friends just simply don't know how to help them and don't know how to connect them with useful resources. So when we educate our patients about this, in ways especially that reduce stigma and shame, and we tell people where you can go for help and where your friends and family members can go for help, we're actually helping our patients help others break the cycle of violence. And we know from other research that altruism is actually a really healing and powerful tool. So patients, we're finding that when these cards are offered, patients are asking for them for multiple friends and family members, and they're taking multiple cards. So by spreading education about interpersonal violence, we are helping people actually feel better about themselves because they feel like they have the skills to help their community members too.